Nathaniel Barry, and this is my PhD confirmation of candidature for the thesis titled Augmenting the Clinical Approach to Glioblastoma, Investigating the Potential of Radiomics to Improve Patient Management. My supervisors are Martin, Pageman, Roz, and McBusher. So glioblastoma is the most common primary brain malignancy in adults, with 5-year survival rates just below 10%, with standard of care treatment involving a maximally safe resection followed by radiotherapy and a concomitant adjuvant temozolomide, which is chemotherapy. Structural MRI, with its excellent soft tissue contrast of the brain, is primarily used for diagnosis, treatment planning, and follow-up. Contrast enhancement on T1-weighted MRI requires disruption of the blood-brain barrier, which suffers from low specificity in identifying active tumor progression from reactive changes to therapy. So management of patient response to treatment becomes difficult, as treatment-related effects can hamper image interpretation. And if available, centers will also leverage information provided by advanced MRI sequences such as diffusion and perfusion-weighted imaging. So I've identified 4 current image-related challenges associated with MRI. The first being tumor characterization, so trying to identify neoplastic versus non-neoplastic lesions, non-invasive grading and molecular characterization, as well as treatment planning for hotspot identification and for biopsy localization, and defining the extent of the tumor burden for target volume delineation. And there's prognosis, so we want to predict progression-free survival and overall survival as early in treatment and as accurate as possible, and differentiation of treatment-related change from tumor recurrence, so where we identify pseudoprogression, pseudoresponse, and radiation injury from glioma. So there are 2 promising modalities that are making headway in these areas, and note that I've actually color-coded these throughout the slides. And so this is FET PET and amide proton transfer MRI. I'll be switching between these 2 quite a lot through the presentation, so I've created these symbols, which will match for the slide I'm talking about. So firstly, FET is an amino acid tracer with a half-life of 110 minutes. Its uptake does not require disruption of the blood-brain barrier, and it has superior tumor-to-background contrast to the more commonly used FDG PET. So an example is shown here on the right. Hopefully you can see my cursor. In image C, there's an FDG PET, and in image D, there's a FET PET. So you can see the lesion is actually really visible there. So according to uptake analysis, a standard administration of 200 becquerels translates to a whole body dose of approximately 3.3 millisieverts. So if we plan to subject a patient to this additional dose, we need to justify it. So in non-invasive grading, FET static and dynamic parameters have been found to vary depending on glioma grade. This is particularly for FET PET dynamic parameters, which are significantly different between low-grade glioma and high-grade glioma. The example is shown here. There's a glioblastoma image on the left over here. And you can see this characteristic early time to peak followed by a descent. And on the right is a grade 2 glioma. You can see the time activity curve is just constantly increasing. Furthermore, glioma grading is now guided by molecular mutations. So glioma grades is divided by isocitrate dehydrogenase mutation, and which can then be further divided by a 1p90q co-deletion. Furthermore, the World Health Organization in 2021, its classification of glioblastoma was now specifically RDH wild type grade 4 astrocytoma. So static and dynamic FET PET parameters are able to significantly differentiate the RDH mutation, although this has not been shown to extend to 1p90q co-deletion, as you can see through the distributions on the right here. Now, a study of biopsy guidance using FET PET hotspot found tumor infiltration in every specimen, and FET PET biological tumor volumes, or BTVs, are assessed with respect to background activity. So we define that using a tumor to background ratio greater than 1.6, which was found to differentiate tumor from peritumoral edema. The crescent-shaped volume of interest is used in background assessment in the contralateral hemisphere. An example is shown on the right over here. And the final BTVs are typically larger than and can often encapsulate MRI-derived volumes. So for prognosis, a higher BTV, maximum tumor to background ratio, and mean tumor to background ratio often indicates a poorer prognosis. Dynamic parameters such as a time activity curve with an early peak and descent is associated with poor prognosis as well as an early time to peak and a negative slope. Relative changes in these parameters from baseline to follow-up have also been investigated, such as in response assessment. An example is shown in this figure here. Patient A has this early time to peak with a descent, and patient B has a later time to peak. And you can see this has pretty big outcomes for prognosis, as shown by survival curves here for progression-free survival and for overall survival. Now, in brief, pseudoprogression often occurs within 12 weeks post-radiochemotherapy and looks like progression on MRI, but it's enhancement caused by treatment. There's also pseudoresponse, which is kind of the opposite effect, and occurs in recurrent glioma and often in combination with anti-angiogenics. FET PET parameters have been found to be superior to MRI in this diagnostic setting. So an example is shown on the right here. We have an early postoperative MRI with contrast enhancement shown by the red arrow. 8 weeks after radiochemotherapy, that contrast enhancement is still there. So it's kind of looking like progression, but on the FET PET, it's actually quite cold. So 16 months after radiochemotherapy, that contrast enhancement has gone away by itself. So this is a case of pseudoprogression. So you can see how that's going to be beneficial for patient management. Now moving on to APT MRI, which is a form of chemical exchange saturation transfer. Signal saturation using radiofrequency pulses on amide protons in mobile proteins and peptides will transfer to nearby water-bound hydrogen atoms. This is shown in the Z spectrum here. So when we do this at water resonance, you get this massive drop in signal. But when we do saturation at the amide proton level, you get that second effect where we get a little bit of this saturation. Saturation here at the over here. And then if we look at this with respect to the other side of the Z spectrum, and we look at what's called the asymmetric magnetization transfer, then we get an image like this over here. So this does not require intravenous administration of contrast agent, which is good for contraindicated patients for gadolinium, and APT signal artifacts can be caused at air tissue interfaces. Now, for non-invasive grading, APT weighted values have been found to be significantly higher in high-grade glioma than in low-grade glioma, sort of similar to what's going on with FET PET. One study found that APT signal intensity were significantly different between grades 2 and 3, 3 and 4, and 2 and 4. And another found that these values were correlated with the tumor grade and Ki-67 labeling index and some MR spectroscopy properties. And this has also been validated via biopsy. So maximum APT weighted guided biopsy sites were significantly higher for high-grade glioma versus low-grade glioma as well. And these biopsy sites were associated with extremely high cellularity and correlation with the Ki-67 expression levels, which is proliferative activity. So for prognosis, similar to FET PET, higher or elevated APT signal is related to poor progression-free survival and overall survival. And depending on the study, some papers will compare the increase in APT weighted signal to contralateral normal appearing white matter, so kind of similar to the tumor background ratio from FET PET. And you can see based on APT signal cutoffs, there's a now drastic difference in patient survival, again for overall survival and progression-free survival. And now higher or elevated APT weighted signal is also able to differentiate pseudoprogression from true progression. So for this diagnostic task, you can see that the receiver operating characteristic curves are actually really informative and highly diagnostic, even compared to diffusion and perfusion parameters. And this is also shown again in another study as well. And now moving on to one arm of my PhD, which is the radiomics aspect, which is the high throughput extraction of quantitative features from medical images. So interpretation of images is currently overtly qualitative within the clinic, but images are full of data waiting to be used to personalize a patient treatment. So we can quantify the spatial relationship between voxels and the tumor volume and characterize lesion heterogeneity. So over here, our doctors have a lot of tools at their disposal to inform on a patient's treatment, but we're living in an ever-increasing digital landscape where a lot of data builds up around the patient as they go through treatment. And so we believe we can use radiomics to capitalize on this in combination with machine learning as an additional diagnostic and prognostic tool to be used by doctors, similar to just using a blood test or something like that. So here's a typical radiomics workflow. We have a patient image here, and we identify a region of interest or volume of interest where we want to extract our radiomics features from. This can be identified by an expert doing delineation or by automatic segmentation like in a neural network. And so we have our volume of interest. We can extract our radiomics features and also add in clinical and genomic data and before we do our model building. But there are a lot of factors that can impact model reproducibility up until that machine learning process. So we need to take these into account to make the most reproducible processes possible. So here's just some of the work that's been going on in FET PET radiomics so far, such as in predicting RDH mutation and also prognosis, such as the use of textural features here to predict early recurrence from late recurrence, and also the diagnosis of pseudoprogression, one using unsupervised cluster analysis, and the other using a random forest as shown up here. And there's also been work in differentiating radiation injury from brain metastases, a little aside from glioma, but the methodology is still the same. Now, in my opinion, APT MRI radiomics has not developed as much. I would say there's a lot of work, but I think it still needs to go a little further. There's been work in differentiating glioma from metastases, as well as predicting the RDH mutation. But we're just now seeing some of those pseudoprogression studies coming out as shown here. And some of the results I'm seeing are really promising, as the APT-weighted imaging information is providing a lot of diagnostic and prognostic powers to the models that are being generated. And finally, both modalities have been combined to great effect in the automated pipeline. So I mentioned this as fully automated pipelines are becoming more common in radiomics. This paper implemented specifically the brain tumor segmentation toolkit, which is an ensemble of glioma segmentation networks on BRATS datasets. So I only mention this now because I'll bring it up later on when I'm doing my aims. So overall, what does the literature suggest for the future of work in radiomics? So where are the holes that we really need to start investigating? So for both, we need further investigation on glioblastoma-only cohorts. For FET PET specifically, there's been significant studies in prognosis and treatment response, although validation of radiomics biomarkers on large prospective datasets with external independent validation is required. Also, BTV delineation can be further streamlined by automated processes, and there are limited studies so far on this. Now for APT MRI, we need more studies on these features extracted for prognosis and differentiation of treatment-related changes, and that opens the door to really begin some retrospective study with internal validation. And so this is my first aim, to evaluate the inter-observer agreement of dose plans and derive FET PET volumes as part of the FIG or FET in glioma TROG 1806 credentialing program. Part 1, to collect required data for processing locally at the Charles Gardner Hospital via secure download from TROG. The integrity of the data must be verified prior to image processing. This will include images and structure files of contours by nuclear medicine and radiation oncology across 10 institutions, and that data collection process is highlighted here. For part 2, as per benchmarking analysis, conduct volume overlap and statistical comparison of volumes defined by nuclear medicine, including 2 time points along treatment, so these 6 benchmarking cases and 2 time points, and 2 observers per institution, so we have around about 20 nuclear medicine physicians, each with segmented background and BTV, and there's also potential to extend this to analysis to include radiomics features. For part 3, as per benchmarking analysis, conduct the same volume overlap and statistical comparison as outlined in sub-aim 1.2 on NMBTVs adjusted by radiation oncologists on 3 benchmarking cases. So it's actually just these 3, the same one, but at FET 1. And this will now include segmented organs at risk. Lastly, each center is also given a benchmarking case to create a radiotherapy plan, and dose plans will be evaluated between centers and techniques to compare dose conformity within target volumes and dose to organs at risk. This will also include toxicity modeling. So this is all the data that is expected to come out from the data collection process. It'll undergo processing here, and then we expect 2 publications from this, one with the evaluation of multi-observer overlap of nuke med contours, and the second being the evaluation of multi-observer overlap of the RO contours and plus the radiotherapy plans. So the progress on this has been really good so far. So all nuclear medicine data has been acquired, which was a very long process with errors in data along the way. Results have been finalized with a significant piece of writing complete and being reviewed by co-authors, and there's a lot of collaboration going on in this project, and some preliminary data just shown in this picture here. So there's also a small amount of RA outstanding data remaining, which will be obtained shortly. The generation of results will not take long thereafter, as the analysis shares a similar pipeline to paper 1. And I've also generated a lot of preliminary results associated with this task as well, as shown in this image here. And so we expect to have a draft by March of 2023. And also altogether, results on both NM and RO datasets have been presented on my behalf by Sue. And this includes at the TROG scientific meeting this year at Cogno, which was a poster presentation. An abstract was recently submitted to ESTRO 2023. And there was also some of this data presented at a recent RANSCA meeting. So moving on to my second aim, to apply radiomics and machine learning to FET PET data. So for the first part, we want to monitor patient accrual from an ongoing national prospective imaging study. So this is the same study, the TROG study. So the first aim was using the credentialing data from the TROG study, and now this is a prospective recruitment part of the study. And we want to do this until the number of available data is acceptable to conduct a machine learning analysis. Data will be processed, feature extraction will be done with appropriate open source software. Robust and predictive features will be chosen to maintain the simplicity and interpretability of the generated predictive model for patient outcomes. Now for part 2, almost in parallel, to develop an automated pipeline to generate the background volume I talked about, required to delineate the FET PET BTV. We want to implement this pipeline within a treatment plan workflow and assess the impact on inter-observer variability when used by nuke med physicians and compared to the current literature. This will be done in collaboration with those in the machine learning cluster who have automatic segmentation experience. And so this is sort of outlined here. So for AIM 2.1, we have to wait for patient outcomes, so survival data. So it's actually likely that AIM 2 will be completed first. But from that data, we'll do our feature extraction. We'll actually identify robust features using the multi-observer data set from AIM 1, do machine learning and analysis, and we expect one publication from this. And then also the automatic segmentation process here, assessing the impact on inter-observer variability and intra-observer variability if we can, and that will result in another publication. So AIM 2 progress, there's not too much to report so far, as we've just been waiting for data to accrue from the study. We will begin to trickle in as much imaging data as possible, as patient outcomes will lag behind. But I'm hoping optimistically to have close to at least all of the image data related to AIM 2 obtained by August. And I think this is a good time to sort of start this analysis, as at this point it's expected that 3 papers will be published or near publication, so it'll be good to pivot onto the AIM 2. Now, finally, for AIM 3, which is the APT MRI sort of part of the PhD, is to implement an automated pipeline for glioblastoma segmentation to necessitate the extraction of radiomics features from APT MRI to evaluate tumor progression. So part 1, an open source segmentation network will be implemented and segmentations will be validated on pre-treatment glioblastomas. And this is highlighted here in the workflow part A. This will require data from a retrospective study. And we have our preoperative data here. And we'll use an automatic segmentation network, which will be the BRATS toolkit, as I mentioned. And then we'll have a neuroradiologist validate those segmentations. Now for part 2, using the validated network, segment patient images within the post-treatment setting. These images will be taken at 3-month follow-up to treatment. Segmentations will be inspected and adjusted if necessary by a neuroradiologist. Contoured volumes will be registered to accompanying ABT for feature extraction. And this is shown here in B. So we have a 3-month follow-up data, a validated network, do some automatic segmentation, have an expert adjust it, and then try and quantify the error there. Now for part 3, features extracted will be implemented in predictive modeling to identify potential biomarkers that can predict patient progression and differentiate true progression from pseudoprogression. Prediction is based on 3-month follow-up imaging, and this will be evaluated against subsequent clinical course and follow-ups. So it's our ground truth. And this is shown in part C. It's just sort of a typical radiomics workflow as shown previously with our feature extraction, feature selection, and modeling. And we're going to incorporate as many clinical covariates as possible, such as demographic, pathological, and also stuff from the radiotherapy plan. The AIM 3 progress has been really good so far. A retrospective study protocol has been developed and submitted for ethics approval, and this is a multidisciplinary undertaking with a lot of clinical input. Ethics approval has been received so far from Sir Charles Gairdner Hospital. The BRATS toolkit has been successfully installed on deep learning workstation in B block. Some inference was conducted on a small amount of test data. That preliminary data was used in a grant application, which was successful, and we'll use those resources for collection of data to commence soon. Now, most PhD students might do a review paper as their first paper, but as data from AIM1 is extremely novel, publication was made a priority rather than a review paper. But a review paper is still planned with a working title, A Systematic Review of Radiomics Applied in Prognostic Modeling Studies of Glioblastoma Patients, Research Quality and Meta-Analysis. So far, 76 articles have been sought for full text review, and the entire process is highlighted here in the prism diagram to the right. And so expected completion of this paper is to be done by June of 2023. Now, this is just the overview. This is the PhD thesis submission. This is a series of papers. So there are 6 total papers planned. And I just wanted to mention that every planned paper is somewhat independent of each other, i.e. the publication of one paper is not contingent on completing the work on sequential papers. So if something goes wrong, as it can happen in a PhD, or we might have to drop a paper for whatever reason, this should not significantly impact the final PhD thesis submission. And just one final notable achievement I'd like to highlight is I've been running the machine learning cluster in cancer research for over a year now, and contribution to student engagement and research quality has been recognised by the school. And so the medical physics cluster recently was given the School of Physics, Mathematics and Computing Award for programs that enhance learning, which I'm really happy about. So I think there's a lot more good to come out of the cluster. And so I'm looking really forward to the future. And so here's just some references for completeness. And thanks for watching. Are there any questions?
Thanks, great, Nathaniel. Any questions from Nathaniel? This is brilliant talk.
So I gotta stay hydrated.
That's good. No questions. That was very clear, I think, Nathaniel.
Well, that's
just-
always
I
good to
got a
hear.
question. If no one else
All right.
does.
Go for it, Jake.
I did put my hand up, but I don't know if it appeared on the thing. Yeah, really great presentation, Nathaniel. That was excellent and clear. I did just have a question about the prospective recruiting study with regarding the machine learning model that you're going to build on radiomics features. You mentioned that you're sort of waiting, I guess, for the patient to trickle in with that prospective study. And you mentioned that there was going to be once there was an acceptable number, you would then start that analysis. Do you have an idea in your head about what that acceptable number is? And I guess a follow-up question would be how many patients are actually planned to be accrued as part of that prospective study?
So I think 100 would be really good. Sort of looking back to just other studies I've seen, sort of like, if you could do like a 70-30 split, it's pretty good. So 100 or around about 80 to 100 would be ideal. But this study is planning to recruit, I believe, up to 210 patients. So there's a lot of, and they're all coming from 10 different centres across Australia. And so there's a lot of data coming through. So I'm pretty confident that we'll be able to reach that mark. So sort of around about that time when I want to start doing that process around mid next year. Well, I think we'll have a significant amount of data from that as well. So hopefully that answers your question.
Yeah, it does. Great.
It's great. So I had a list of questions, but you answer all of the questions during your presentation.
Well, it's always good to hear that.
That's great. So it was, as Jake said, it was very clear. So I'm pretty sure Mubashir and Martins are happy with no questions, and if there is no question, so
Also per point.
excellent. That's great.
All right.
Thanks very much,
Thanks for listening, everyone.
Nathaniel and Martin. If you could please